Good morning to all of you. It's amazing to see so many people here on a Sunday morning, a Saturday morning. I'm ahead of time here. But it's wonderful to see you all here. I'm happy to be here, and I'm happy to be talking about a medical condition that I'm very passionate about and I feel very strongly about. I have several family members with osteoporosis, including my own mother. So it is a topic that is very close to my heart. So I feel very privileged to be here, standing here talking in front of you. I would also like to thank Dr. Barry Shibuya, Victor Mo, and his entire team for putting this seminar together and having us here. I just want to let you know that I have no conflict of interest. I have no financial or other conflicts of interest. And just a disclaimer that this is a general overview of the topic. This is not really specific medical advice. I would still recommend that if you have any specific questions to go to your healthcare providers. The reason why we're all here is because osteoporosis is a very preventable and treatable disease. And I really want to put a lot of focus on the prevention today in our talk, because there is so much we can do to prevent people from getting osteoporosis. And I think that is where you guys should feel empowered to make sure that you do not get this disease, to help your family members, to help your children, help everybody around you, and talk about this so that we do not develop osteoporosis. This is a disease that affects both men and women. If you look at osteoporosis in people over the age of 50, there's an incidence of 4.5 million in women and about 0.8 million in men. If you then include osteopenia, the numbers are staggering. You see a much higher number of people with osteopenia, which is a low bone mass, which is the stage before osteoporosis. You can see almost 22.7 million women and 11.7 million men with osteopenia. So it's very important that we talk about this, because the incidence, all combined incidence, is higher than the incidence of breast cancer and heart disease put together. So very high numbers, and we really should be talking about this. What are we going to talk about today? We're going to talk about what is osteoporosis, why we are talking about it, what is the impact, what is the problems or the complications of osteoporosis, what are the risk factors, what predisposes somebody to get osteoporosis, how is it diagnosed, blood tests, x-rays, exam in the doctor's office, what are the things that are used to diagnose it. What is the management? Again, with a lot of focus on prevention. We're going to talk both about prevention and treatment, and the newer things that are upcoming. Before we talk about osteoporosis itself, I just want to let you all give you some background. Bone is a living tissue. Throughout your life, there is formation of bone and there is loss of bone. There are cells called osteoblasts which help you make bone, and there are cells called osteoclasts which help you make the loss of bone happen. It's not as simple as that, but I think for the purposes of this talk, just knowing what are osteoblasts and osteoclasts would be very helpful. Throughout your body, if you look at your cycle of bone that happens in your body, if you look at this side, it's the loss of bone, and if you look at this side, it is formation of bone. Think of this as a bank account. Think of depositing money and taking out money, okay? The more you deposit, the more you can take out later. So this part of the cycle is very, very important. You need to build a lot of bone, and particularly when you're young, you need to work on improving your bone density, and we'll talk about how you can do this. But the low calcium state in your body will stimulate the cells that break down bone and liberate calcium into your blood. When that happens, the calcium will then enter the bloodstream and it will make the bone very weak. That's when the osteoblasts, which are the cells that make bone, get stimulated, and you will have then them joining again back with calcium to strengthen bone, and then the bone gets returned to a normal state. So this is the cycle of bone regeneration and degeneration, that's happening throughout your lives. The balance is a little bit different at each stage, and we will talk about that as well, but this is the general gist of what happens. What is the definition of osteoporosis? In 1993, osteoporosis was defined as a disease which is characterized by two things: low bone mass and deterioration in the microarchitecture. So basically, the amount of bone you have goes down, but that's not enough. The architecture of the bone gets changed. The characteristics of the bone get changed. The quality of your bone gets changed. So there are two parts to this, and both of those need to be addressed. And because of that, your bones become fragile, they become weak, and then they tend to break down. There was a more recent definition that was put by the NIH Consensus Developmental Panel on Osteoporosis. This is a more simplistic definition. This just describes osteoporosis as compromised bone strength predisposing you to fractures. But I think this is a more specific, more detailed definition of osteoporosis. So if you look here at this picture, this is comparing a normal bone to an osteoporotic bone. And you can see that the thickness of the bone is affected, which is the bone mass. But you also see that the interlinking here, which is the architecture, is lost here. You can see how the linkages are broken. The bone is not linking to each other here. So that is the architecture of the bone that has changed. I have a couple of more pictures here, very specific to the hip here. This is healthy bone, and you can see what happens in here. You see the changes, the cystic changes that are happening. There are holes being formed inside your bone, and you can see how thin and fragile the bone starts looking. And then this is your vertebrae, this is your spine, and you can again see the difference between the two. This probably is one of the most important slides that I want you to focus on. This is the bone density as a function of age, both in men and females. If you look here, from 0 to 30 is when you reach your peak bone density. You build the maximum amount of bone in your formative years. So it's again very important to talk to your children, talk to your grandchildren about how important it is to be active, how important it is to be, to take their calciums and build that peak bone mass at a higher level. From 30 to 50, there is a very gradual decline in your bone density. And then after 50, which is after menopause here, you can see that there is a much more rapid decline. In men, it's usually a very, very gradual, steady decline through their years, but in women you can see after menopause that there's a big drop. So this is, shows you how important it is to reach that peak bone density. The reason we're so concerned about osteoporosis is because it's called a silent thief or a silent disease. You oftentimes do not know what's happening in your body. You don't know that you already have osteoporosis till you break a bone. And that is why it's important to be aware of it. Go see your doctors, get your bone densities done, look at your risk factors and assess whether you could have that condition and try to prevent it. Otherwise, you're going to find out later after you already break a bone, and the news may not be so good at that point. So it's very important to be aware that it is a silent disease and it can be prevented. What is the impact of osteoporosis? There are several impacts, but the major ones are physical, okay? If you look here, your height will start decreasing. You can become shorter. The other impact is your spine. The upper part of your spine starts curving up, and this curvature is called kyphosis. So people start hunching over and become shorter. The health impacts of this: as you become shorter, your posture changes. Sometimes you cannot look up, and the risks of falling are higher, the risks of breaking a bone are higher. Also, it tends to compress your chest cavity. So you can have shortness of breath while walking. So because of all this, it's very important to understand and be able to treat osteoporosis. The other issues with osteoporosis we'll talk about more in subsequent slides. Remember, the bone structure or the skeletal structure in your body is very important, because not only does it give support to the muscles, the tendons that attach there, but it also protects a lot of your internal organs, your heart, your lungs. So bone health is very important. This is the other impact of osteoporosis. The number of fractures from osteoporosis are very high. The number of hospitalizations because of those fractures are very high. The trips to the emergency room, visits to the doctor's office, people placed in nursing homes, these are all very high impacts of osteoporosis. And we really need to bring these numbers down. The most common result of osteoporosis is a broken bone. I always tell my patients, think of a building. You have supporting beams in your building, pillars that are there. If you start making holes through that pillar, at some point the whole building is going to collapse. That is the same with your spine, with your hip. They are the pillars of your body. They support your body weight. If you start getting holes in them, porous means holes, or porosis is porous, it means holes. You're starting to get fragile, weak bones. The entire structure at some point will collapse. You start getting compression fractures in your spine. They're excruciatingly painful. You get hip fractures. The most common site for osteoporotic hip fractures is in the part of the bone called the femoral neck. So if this is your femur, this is the neck of the femur, and this is the ball. This is the weak point, and this is where you're going to get most of your osteoporotic fractures. The amount of morbidity and mortality after these fractures is very high. The third most common site for fractures are the wrists, but the main issues are the spine and the hip. The financial burden of osteoporosis. This includes the direct costs. You break a hip, you end up in the hospital, you're going to the emergency room, you get a hip replacement, then you have to go through rehabilitation, spend time in a long-term nursing care. So the costs are very high. The indirect cost is the morbidity, which is, you're not independent, you're laid down in bed, loss of working days if you're working. Other things are the poor quality of life. A lot of people don't regain their normal lives again. They are dependent on other people. And also the amount of your family that is going to spend time in your care. In the US, in 2002, the estimated direct cost of osteoporosis was $16 billion and is only expected to increase by another 50% by 2025 if we don't do something about it. And hip fractures incur the highest cost. If you compare the hip fracture cost, one person has a hip fracture is $8,600, which comes up to an annual cost of about $14 million. You compare that to the treatment, it's only $500 per person. So that's a huge difference in the cost. When we think of osteoporosis, we only think of osteoporosis in women, but it is just as prevalent and as common in men. And the incidence of hip fractures may be about the same, but the morbidity or the long-term death or mortality is much higher in men. So we should also be discussing about treating men, diagnosing men, because it is a very high risk of morbidity as well as mortality in men as compared to women. In men particularly, a forearm fracture is a very early and sensitive marker. So if a male comes to the physician with a forearm fracture, the first thing that crosses our mind is he osteoporotic? Does he have osteoporosis? And that's one of the very early markers. What causes osteoporosis? There are things that make you lose bone, and then there are things that, reasons why you don't build bone. You could have an underlying medical condition which prevents you from making bone through your life. And so there are different causes of osteoporosis. We particularly talk in terms of risk factors. Risk factors are things that predispose you to osteoporosis. It is not necessary that if you have the risk factor, you have to develop the disease, but more often than not, if you have the risk factors, your risk of developing the condition is much higher. There are things that you cannot change. Family history. If you have a mother, father, brother, sister, a first-degree relative who has osteoporosis, you're very likely that you're going to get it. Increasing age, particularly after the age of 50 in both men and women, the incidence of osteoporosis starts going up. Osteoporosis is 3 times more common in men than women. 3 times more common in females than males. So being a female is a higher risk of having osteoporosis. Race and ethnicity matter. Osteoporosis is more common in Caucasians and Asians, and much lesser incidence in Hispanic and African Americans. The other risk factors that you cannot change, the small skeletal framework, and part of the small skeletal framework is related to the ethnicity. It's related to, where you come from. But also premature menopause. If you have had menopause before the age of 45, it increases your risk of having osteoporosis. If you've already had a fragility fracture, you already have osteoporosis. So that's a risk factor that you cannot change. There are also certain medical conditions like inflammatory arthritis, rheumatoid arthritis, lupus, psoriatic arthritis, inflammatory bowel disease, diabetes, problems with your thyroid or your parathyroid that increase your risk of having osteoporosis. If you've had a gastric bypass surgery, it increases your risk. If you have celiac sprue, it increases your risk. Things that you can change, and this is very important. Again, we talk about the low peak bone mass. If you haven't achieved the bone mass that you should or can, then you actually run the risk of developing osteoporosis. So this is something you should be able to change when you're young. If you smoke, there is a higher incidence of osteoporosis. Smoking also can increase your risk of premature menopause. It actually makes you lose estrogen faster and actually can get you into premature menopause. Alcohol, more than 2 drinks a day. Alcohol is very toxic to the bones. It makes you lose calcium, so your risk of osteoporosis goes up. If you're not taking enough calcium, and we will talk about calcium at depth, it can increase your risk of osteoporosis. Vitamin D deficiency, which is very common now. Almost 50% of people have vitamin D levels less than 20. So that can increase your risk. And inactive lifestyle, if you're very sedentary, you don't do much, your bone loss can be pretty quick. There are certain medications, and I've put this under a risk factor that you can change, but sometimes there are people who need to be on these medicines and you really cannot go off of them. But if there is a possibility of taking less steroids or lesser of any of these medicines, then that's something you should talk with your physician about, because they certainly increase your risk of osteoporosis. How do we evaluate for osteoporosis? So there are many things we use. When you come into the doctor's office, we check your height. We look at your posture. We talk to you about risk factors. We ask you about your family history. We ask you whether you've been taking enough calcium, whether you've been exercising. The main testing method we use is a test called DEXA scan or a bone density. Sometimes we do blood tests to look for other causes of osteoporosis. And occasionally, we don't use an X-ray as a diagnostic method, but sometimes if you had X-ray for another reason and we see that your bones look very thin or osteopenic, that can be a clue for us that maybe you do have it and we should test you for it. How do we diagnose osteoporosis? The gold standard, the test we still all rely on, which is still the most important predictor of osteoporosis and your fracture risk, is a bone density or a DEXA scan. The DEXA scan stands for dual energy X-ray absorptiometry. This is a very easy test to do. It is not painful. It has very less radiation. You go lie on a table and something moves over you. So it's a very simple test to do, unlike some of the other screening and preventative tests that are done. So encourage everybody, if you're in the right age group, if it is indicated, to have this done. It's not a very complicated test to do. If you are on treatment, if you already have osteopenia or osteoporosis, oftentimes we will repeat a bone density every couple of years. We prefer if you do the bone density on the same machine each time or at the same place, because then we can compare the results. The recommendations for testing. For women, all women over the age of 65 should definitely have a DEXA scan done. Between 60 and 65, if you have risk factors that we already talked about. In men over the age of 70, or if they have multiple risk factors. All people who have already had a fracture, who are above 50, should definitely get it. If you have reasons to worry about secondary causes. If there is other underlying medical conditions because of which you could have osteoporosis, you definitely should get tested. We often test even young patients who are on steroids long term, more than 5 milligrams a day for more than 3 months. We will test them, and oftentimes we will even treat them even though they're really young and even below the age of 50. This is the interpretation of the bone density results. This is probably what a lot of you would have seen if you've already had a bone density done. A normal number is -1 or higher. A low bone mass, which is osteopenia, is between -1 and -2.5, and osteoporosis is -2.5 or lower. I think these three are the numbers you probably need to know. This is another way of looking at it. Anything that is in the positive after -1.0, anything in the higher range is all normal. Anything lower than that, up to -2.5 is osteopenia, and less than -2.5 is osteoporosis. I really like this slide because again it shows us how important the peak bone mass is. So this is somebody who had a very low bone mass. They didn't achieve a very high peak bone mass, and you can see that, you know, by 35 they're already in the osteopenia range, and then you come to 50 and they're rapidly losing bone, and by 60 they're already in osteoporosis. Compare that to somebody who has reached a much higher bone mass. They are losing bone at the same rate. The curves are parallel, but it takes them a lot longer to get to osteoporosis. They are at 80, they're still not osteoporotic. Somebody who has an early menopause, loss of estrogen, rapid decline in bone, and here is somebody who probably has a medical condition, who's on steroids, they start losing bone quick too. But you can see that the higher the bone density and the peak bone mass you reach by 30, the more, much better it is. You don't, you know, get to osteoporosis that fast. This is probably what you see when you look at your results with your doctor. I just want you to focus on the T-score and the Z-score. The Z-score is the number that compares you to people of your age, which is not what we're interested in. We don't want to compare you to an 80-year-old or a 60-year-old, because then the results are not going to be good. But what we're really interested is in the T-score, because it compares you to a young adult. We want to compare your numbers and see where you are at compared to a 30-year-old. And we want you to maintain your bone density at that level. So what most physicians, all physicians, really focus on is your T-score. So that is the number you need to know for your spine and your hip. In the management of osteoporosis, we will talk about lifestyle changes, changing all those modifiable risk factors we talked about. We'll talk about dietary changes, supplementation, treating the underlying cause. We'll talk a little bit about osteopenia, when we should be treating. Not everybody needs to be treated. We will talk about how we treat osteoporosis, and then also talk about preventing falls. Prevention, first we need to check our risk factors. If you're smoking, you really need to stop. If you drink more than 2 drinks a day, you need to kind of reduce your alcohol intake. There's little different recommendations for men and women, so definitely talk to your doctor, figure out how much is okay, but that's definitely 2 things you can stop. We will focus a little bit more on calcium, vitamin D, weight-bearing exercises. I kept the medications here because if it's something that you can discuss, if you're on prednisone, you can cut it down, definitely it's something you should discuss with your doctors. Physical activity, one of the most important parts of prevention. Moderate weight bearing. What do we mean by weight bearing exercise? It means you're exercising against gravity. So walking, elliptical, treadmill, bike, dancing, all those are considered as weight bearing exercises. It's not bad to do swimming or water aerobics, but that's not considered a weight bearing because you're not doing it against gravity. You have the buoyancy of the water. So it's low impact, it's not weight bearing. That's not going to help you that much with your osteoporosis. At least 30 minutes a day. Even things like walking around your house, walking in your backyard do count, but 30 minutes every day is what is recommended. Be careful though, don't fall, because that would be a worse outcome. So make sure you're safe when you're exercising. Strengthening exercises are very important because the stronger your muscles are, the more balance you will have, the less chances of falling. Also, flexibility exercises are very important. We don't want you to do like heavy weights, but just light weights, multiple repetitions a day is very good for you. We'll talk a little bit about calcium. Very important. You need to know how much calcium you need at different age groups, but for the purpose of this talk, men, women before menopause or premenopausal around the time of menopause, postmenopausal women who are taking estrogen, they need about 1000 milligrams a day, and postmenopausal women who are not taking estrogen need a little bit higher. They need about 1500 milligrams a day. Okay? Oh, did I press something wrong? So everybody thinks that you need to take supplements. It's not necessary for everyone to take supplements. Diet is a great source of calcium, but dairy sources are the most and the biggest source of calcium. If you cannot drink milk, if you cannot eat cheese, if you cannot, you can't eat ice cream because you have diabetes or cholesterol, then soy milk is an option. But there are lots of foods that have calcium in them. Lots of green leafy vegetables, broccoli, kale, butternut squash. There are lots of things that are not on this list. You can go and look it up. You will be able to pretty much find which food has how much calcium in it. There's fish, white beans, tofu, eggs. They all are sources of calcium. So try to get as much calcium as you can from your diet. That's the healthiest way to do things. If you still are not getting enough, then you can always take supplements. And we will talk about the different kinds of supplements available. But I can't emphasize this enough. Everybody thinks they need to be on supplements. It's not necessary if you can get it from your diet. How do you read a food label, right? If you go to buy milk, how do you understand how much calcium is there in it? So this is from low-fat milk or skim milk, this label. So first you need to know the serving size. 1 cup of milk has 30% of calcium, okay? You just add a 0 to that, whatever number you see, you add a 0 to that, and that's the milligrams you're getting. So if you drink 1 cup of milk a day, you are getting 300 milligrams of calcium. If it is 25%, I think 1% milk has 25%. So if you add a 0 to that, you're getting 250 milligrams. So if you drank 3 cups of milk a day, I mean, a lot of us probably don't drink 3 cups of milk a day, but if you did, you already are getting 900 milligrams of calcium for that day. The only thing you need is supplements, or additionally from your diet is the rest of it. So remember, just add a 0 and you know how much calcium is there. Oh, I keep pressing the wrong thing, sorry. Supplementation. There are many different kinds of calcium supplements, but the most common ones we use are calcium carbonate, citrate, I tend to use this a lot and we'll talk about why, and calcium gluconate. Again, you need to know the serving size on the bottle. How many pills does it say? If it says 2 pills give you 500 milligrams, you need to calculate how much is the real amount of calcium you're getting. That is called the elemental calcium. For example, with calcium carbonate, if you take a 1000 milligram pill, you're getting 400 milligrams of elemental calcium. That is what you need to know. So if you take 3 of them a day, then you will have 1200. So you need to know the amount of milligrams, how many pills for that, and the elemental calcium that is in there. But if you can remember just for calcium carbonate, citrate and gluconate, that is pretty good. Calcium citrate has moderate amount of elemental calcium. For every 1000 milligrams, that's 210 milligrams of calcium, but it is more soluble. So you can put it in a glass of water, let it dissolve, shake it up a bit and then drink it. It's easier to take. It is also better tolerated. There's less stomach issues with it, less constipation, less gas with it. It is a little bit more expensive than the other two, but it may be worth it if tolerance is an issue. Calcium carbonate has the highest amount of elemental calcium. It has 400 milligrams per 1000 milligram pill. It's the least expensive, but it's much more difficult to tolerate, a lot more GI issues. Calcium gluconate, I don't recommend it as much because it has very little elemental calcium, so you need to take a lot to get the amount you need, but it also has better tolerated. Remember, calcium has to be taken in divided doses. You don't want to take more than 500 or 600 milligrams of elemental calcium at one time. Your stomach just cannot absorb it. So I have patients who come and tell me, oh, I'm taking 1200 milligrams, but all at the same time, you're not getting the benefit of it. You're not absorbing it, so it's, you know, ultimately you're just getting the 500 or 600. Preferably take it with food. The absorption is much better if you take it with food. The calcium pills are usually big horse pills. They're large, they're big and difficult to swallow. But, you know, you can crush them and take them with your food. I often tell my patients to crush them and put it in a glass of orange juice and drink it. But yeah, you can crush them and take them. You can even chew them. They don't taste bad. They taste chalky, but they don't taste bad. It's not bitter. It's not something you're probably not going to throw up. But it's just a chalky taste. But you can definitely crush them and take them. I know they're very difficult to swallow. They're huge. Vitamin D, there are very limited sources of vitamin D. There is egg yolks, mushrooms, soy, fish oil. But it's very limited. The amount of vitamin D you get from food is not much. The main source of vitamin D is your body. You make vitamin D on your skin from sunlight. The problem is a lot of us don't go out much in the sun. A lot of us, people make different amount of vitamin D. Darker skinned people make lesser vitamin D than lighter skinned people. The melanin in your skin protects your skin from the UV rays, and so you don't really make that much vitamin D. A lot of times we're worried about skin cancers. So a lot of us don't want to go out, and if we go out, we put sunscreen. Even the lowest amount of SPF 10 or 15 prevents the UV rays from getting to your skin and making vitamin D. So vitamin D deficiency is very common. You can see levels less than 20 and 50% of people. So for the purposes of just not being able to predict who's making how much vitamin D, we recommend a supplementation. 80 to 100 milligram, 80 to 1000 international units. So it doesn't come in milligrams, it comes as international units, is what we recommend for maintenance. Oftentimes we will check your levels, we will see if you're deficient, because if you're deficient, you need much higher levels, much higher dosage of vitamin D, and oftentimes you can get a prescription for it. Treatment of osteopenia and osteoporosis. Everything that we talked about in prevention is still part of the treatment. The calciums, the lifestyle changes, the vitamin D, the exercise, it is part of treatment as well. So once you develop osteoporosis, you don't have to stop doing all that. You still need to do everything. You still have to do all of it. But there are other things we can do in terms of treatment. Again, we'll talk about osteopenia, medications, fall prevention, and bone turnover markers. Risk assessment for osteopenia. This is a tool that was developed at the WHO Collaborating Center for Metabolic Disease at Sheffield University in UK. It's a very freely available online access. Do we have internet access? Can I go through that link, or you don't think it's possible? Oh, okay. So I have the link here for you. What this does, in the past when people had osteopenia, we treated them if they were lower than a certain level, and I think it was like minus 2.3. But now what they have come up with is they look at your bone density and then they assess your risk. They try to figure out, are you somebody at high risk for developing fractures? In which case you should be treated, and if you're not, then you don't necessarily have to be treated. You can repeat a bone density in 2 years. So when you go online to this website, it will ask for your race, your ethnicity. It gives you specific information. You can plug in all your answers. There's a questionnaire that comes down. It will ask for your risk factors. Do you smoke? Do you drink? Do you have a family history of osteoporosis? Have you had a fracture before? It will give you all that information, and it explains the risk factors too if you have questions. So you can plug in that information. And then if you have your bone density results, it asks for the T-score of your femoral neck. You can plug that in and it will ask you what machine it was done on. Oftentimes it will be on your results, and it will tell you what is your risk for fractures in 10 years. And based on that, a decision is made to treat or not to treat. Nowadays, when you go to have your bone density done, a lot of those places already give you this in the form of a paper and ask you to fill the information. So when we get the results, we will get your FRAX score along with the results if you have osteopenia. Who should be treated with medications? If you've already have, and what I mean by fragility fracture is somebody, with no trauma. You're sitting, you cough and you break something in your vertebrae. You sneeze and you get a compression fracture. You just trip over a little and you break a hip. Those are called fragility fractures, non-traumatic fractures. If you have a history of those fractures, you are already considered osteoporosis no matter what your bone density says, and you get treated. If your T-score is less than -2.5, you get treated. And for osteopenia, which is the low bone mass, where the T-score is between -1 and -2.5, we use the FRAX risk assessment. If your risk for 10-year risk for an osteoporotic fracture is more than or equal to 20%, or specifically for the hip, if it is more than 3%, then you do get treated. And we'll talk about the medications in a little bit. So these are the indications for treatment with additional medications. I'm not going to spend too much time going into details about the medications because there is a lot of information. It probably serves you better if you sit down and talk about what's the best medicine for you and the pros and cons of those treatments. But I'll give you a brief overview. There are two categories of medications that are currently available that are FDA approved. Are we doing okay on time? Okay. So there are two broad categories. One is the anti-resorptive agents, and there is only one that is called an anabolic agent, which is teriparatide. So anti-resorptive agents, they prevent bone loss. They don't build new bone. They kind of tip the balance over so you don't lose too much bone, but they're not helping you make bone. The anabolic agent, there's only one currently FDA approved, is the only medication that helps you build new bone. Among the anti-resorptive agents, there is hormone replacement. There's something called SERMS, which is serum estrogen receptor modulators, calcitonin, which is a nasal spray. Bisphosphonates is the most commonly used group of medications. We'll talk about it. And then there's denosumab, which is a 6-monthly injection. Teriparatide is also called Forteo. It's parathyroid hormone, and it's a daily injection. Hormone replacement, the most commonly used is Premarin. You want to make sure that the estrogen levels are 0.6 to 5 or more. Anything less than that is not really helpful for your bones. It has shown to decrease both a decrease in vertebral fractures and improve the bone density. So when you're treating, you need to look at two things, right? You need to look at not just improvement in the bone density, because it may improve and you may still get a fracture. So we look at two outcomes. One is an improvement in your bone density, but also that people get less fractures. So there are two outcomes that are important. So here it decreases, it has been shown to decrease vertebral fractures, not necessarily hip, and improvement in the bone density in both the spine and the hip. It does have increased risk. There is increased risk of breast cancer, increased risk of clotting. The consequence of clotting is deep vein thrombosis in your legs, strokes, cardiovascular risks, bleeding, spotting, endometrial cancer. The SERMS is RALOXIFENE. It's also called Evista. I tend to use this more in osteopenia, not in osteoporosis. I don't use it as much for osteoporosis. I don't feel that the data is very, the numbers are very good for osteoporosis. It does show an improvement in bone density in spine and hip. It does decrease vertebral fractures. There is decreased risk of breast cancer, no uterine bleeding or clotting, but can cause hot flashes, leg cramps, and increased risk of clots as well. Calcitonin, it's a nasal spray, very easy to use, very safe, but it's also very mild, doesn't really work. So there is a very, very small window in which I use it. There's a very small number of patients in which I use it. If they cannot really do anything else for various reasons, whether kidney problems, underlying medical issues, then I tend to use this. But the benefits are not that much, but it is safe. It prevents new vertebral fractures. The risks are minimal, usually because you're spraying it in your nose, you can get runny nose or bloody nose and sometimes headache, but really nothing, it's pretty safe and easy to use. The bisphosphonates, there are currently 4 available. There is alendronate, which is also called Fosmax. There is Actonel or Risedronate, which is Actonel Atelvia, and then there is Abandronate, and then there's a once a year injection called zoledronic acid. The other three are pills. Boniva is also available as an IV, and the zoledronic acid is a once a year injection. The nice thing about this is it can be combined with other agents. You can combine it with hormone replacement, you can combine it with Evista. The biggest issues are GI irritation. If you have esophagitis, you have gastritis, you have reflux, then a lot of irritation, sometimes even chest pain. Bone pains can happen, they can last for several weeks. Usually it's mild aching, but I've had a few patients over the years get off of it because the bone pain was too much to tolerate. The two reasons these have come into negative press, one is osteonecrosis of the jaw and one is atypical hip fractures. And I'm sure over time somebody, a lot of you might have read about it. These are not common. These are very rare considering the number of people that are on these medications. The incidence is not very high. Osteonecrosis of the jaw, osteo is bone, necrosis is death. So a part, if you have extensive dental surgeries, a part of your jawbone can get absorbed and the bone gets exposed. And because of lack of blood supply to that area, you need to talk to your doctor if you have jaw pain, and then you can do CT scan to figure out what is wrong, and you need to get off the medicine. But again, this is more common in people who have had cancer and are on radiation, who have dental abscesses, very poor dentition, need to have major dental work while you're on this. If somebody needs to have major dental work, I hold off on starting the medicine. I usually wait till they complete their dental work and then start it. So again, something to be aware of, nothing to be terribly concerned about because it is not that common. Atypical hip fractures, again something more recently that has come to light. Considering the number of patients that are on this medicine, it's not that common. But after several years of use, after 5 years of use, this non-fusion fracture, remember I told you that the neck of the femur is the most common site for osteoporotic fractures. In this, there is a greater trochanter on your femur. You can get the fracture just below that. It's an unusual kind of hip fracture that is in the stronger part of the bone. If you have pain or pain in your leg when you're on this medicine, you need to let your physician know so that they can assess for it. Oftentimes you need an MRI to diagnose it. It may not show up early on an X-ray, and that needs to be fixed. You need to get off the medication. Currently, after 5 years of using these medications, I sometimes will recommend what's called a drug holiday because of this atypical hip fractures. How you approach it? If the patient is at high risk for a typical osteoporotic hip fracture, I'm probably not going to take you off of it. I'm probably going to leave the patient on it. But after 3 to 5 years of therapy, you need to reassess the patient, talk to your doctors, get a bone density done, see what is your risk. If you're a low risk patient, you don't have too many other issues going on, you're not on steroids, you've not had a fracture before, you can safely get off the drug for a couple of years. But this needs to be assessed on a case-to-case basis. Not every patient, even though recommended, can go off the medicine after 5 years. The denosumab is a 6-monthly injection. It's a fully human monoclonal antibody. You don't necessarily have to know the mechanism of action, but again, it's an anti-disruptive, prevents bone loss. The risks most commonly infections. Based on the studies, I really haven't had a patient with that problem. It can be at the site of injection, it can be anywhere else. The data is very good. It decreases fractures in the spine, hip, and non-vertebral, and increases the bone density. So it may be even a little bit better in terms of the data compared to the bisphosphonates. We use it a lot in our practice. Teriparatide is the self-injection. Kind of reserve it for people who failed other agents, who have severe osteoporosis, a lot of fractures. It is very, very expensive. It's a form of parathyroid hormone. A lot of patients hesitate because it is a daily injection, but remember, family members can help you out there. We usually use it only for 2 years because of some studies that came regarding osteosarcoma in the bone, but those were lab studies. Not so much concern for it in clinical practice, but we still currently limit its use to 2 years, after which we change you over to one of the other agents we talked about. It increases the bone density at a faster pace because it's actually growing bone. You can have nausea, dizziness, cramps, body aches. Sometimes increased calcium levels. You would know increased calcium levels by constipation, nausea, vomiting, feeling of weakness. So if that happens, we will check your calcium levels. The biochemical bone markers, these are not diagnostic tests. These are just used. We have serum markers and urinary markers. We have markers that reflect bone increase. We have markers that reflect loss of bone. We only use it to test the effectiveness of the drug, whether it is suppressing your bone turnover too much. But we don't use it for diagnosis. These are the commonly used bone turnover markers, but the ones we tend to use most are the NTX and the CTX in our offices. I can't emphasize this enough. If you have osteoporosis, if you have osteopenia, please make sure that you're safe, you don't fall. Strengthening is very important. Muscles have to be strong to keep you steady. There are lots of places, physical therapy places, that will do balance and gait assessment, do gait training. So consider going to physical therapy to have that assessed. If there are vision issues, cataracts, address those, get the cataracts taken care of to prevent falls. Very important, I always tell family members to go home and assess the house, declutter the house, make sure there's plenty of room to move around, take out any loose rugs or things that people can trip on, keep a flashlight next to their bed if they get up in the night to go to the bathroom so that things are well lit. If you have banisters or stairs that they're walking up and down, make sure that is sturdy, not wobbly. Shoes are important. Wear wide heels or preferably flats or sneakers. You don't want to fall. Also very important, wonderful, that's perfect. Go slow, don't be in a rush, think before you walk, watch your surroundings, don't go and trip just because you were in a rush, just slow down. There are lots of future therapies. I'm not going to get into the details. There are anabolic agents which increase bone growth. There's some that do both, especially anti-sclerostin antibodies. Great preliminary data. They increase the bone as well as decrease resorption. So some really exciting times, some new things coming around. But if we could all get to prevention and not get osteoporosis, that would be the best. So this is a disease of the bone. Prevention is the best. Treatments are definitely available. All of you make sure you talk to your healthcare providers about it. These are resources. You have the Arthritis Foundation, the American College of Rheumatology, the National Osteoporosis Foundation, and 4 is a local foundation here based out of Oakland. A lot of great information on their websites. Please go, please refer to them, read about it. And that's the end of my talk today. If you have any questions, I'd be happy to answer. Thank you.